Welcome to the Eyecare experts, Dr. Bell, Dr. Terrezza, and we have with us Dr. Martin again. Thank you for joining us. And yeah, I mean, you've been here before certainly, but give us a little bit. I think everybody's interested always as far as background. You know, where'd you go to optometry school, and anything else you want to share?
Yeah, all right. So I'm originally from Ohio. That's where I grew up. And then I went to optometry school in Philadelphia at a school called PCO. And then I did my residency at the Baltimore VA and Johns Hopkins in Baltimore. That was specialized in ocular disease, but we kind of did a little bit of everything. And then I worked a little bit in Maryland, and then I moved here and started working with these guys. So it's all been good.
Impressive.
Thank you.
Well, just jumping into the topic today, I know we've got a lot to to go through with this. It's not, I guess you're hearing a little bit more about it nowadays, but cortical visual impairment. And with that, I think we're talking about the eye versus the brain sort of thing, information processing. As far as the definition, the one that I kind of pulled off with cortical vision impairment, CVI, it's brain-based condition where the eyes see normally, but the brain has difficulty processing the visual information, which leads to reduced vision. So I guess the catch here is it's not because they can't see 20/20 because the glasses or the prescription is off. There's something that has happened, whether it be premature, whether it be an injury, a developmental issue or stroke, or something that's causing them not to see what we would consider 20/20 or good vision. There's something that's reducing that vision. And there's a lot of things, when you look under this, that actually could contribute, that could lead to what we call CVI. What do you think, study-wise? You got something specific on it, or what you got?
Well, it's...
Enlighten us.
What causes this is a lack of oxygen or blood supply to the brain, basically.
Okay.
And hydrocephalus, when there's too much fluid on the brain, can cause this. Infections that reach the brain, head injuries, and certain genetic conditions. So it's not as rare as you might think. There are 180,000 cases a year in the United States.
Right.
Most docs, really, you have to be either a pediatric optometrist or a pediatric ophthalmologist to deal with this syndrome. And the treatment of it, gosh, the symptoms are, they don't respond well to things they see. They see parts of things in front of them. They have trouble recognizing faces, and it's very hard to pin down, actually. Yeah. What you do is get a general eye exam first to make sure that it's nothing routine.
Right.
And then refer up the ladder to do that.
And I think kind of going along with that, a lot of times if someone's having trouble seeing, we're thinking it must be eye related, and you kind of said this, but it's, in this case, what happens is your eyes are working, but then that information has to go from your eye through a pathway back through your brain. And if the eye is working, but the pathway in the brain has something going on, it won't be able to process that information. So on the eye exam, everything, should come back fairly normal with the eyes, but there's trouble with the vision.
And it's hard to pin this down. Sometimes it depends on the age of the child, but they'll have what's called, and I learned this in reading about this for this podcast, Anton syndrome, which means they deny that they have visual problems because of peer pressure to fit in with the rest of the kids and just to be considered normal. And that makes it very hard to diagnose. And they will adapt quickly trying to get by, but ultimately they fail.
And this is, just saying that last part there, this is the reason, even if you had say any parent out there, any kid that you have, even if they, they don't say they have any problems, they don't, you don't notice any problems, certainly bring them in. Let's check them, make sure both eyes are seeing well, make sure everything is healthy, because some things, to your point, won't show up unless we kind of break it down, right eye, left eye, look at the vision distance in the ear, look inside the eyes, because a lot of kids will kind of maybe close an eye, tilt a head, maybe avoid a task, maybe not read long, kind of just avoid instead of saying, hey, I can't see out of my left eye. They don't say it like that. They just may avoid using it, and some things don't show up until we start looking for it.
And if their vision has been like this their whole life, they may not
true.
understand that that's not normal, until we start doing the testing and realize that they're having trouble with certain things.
Concomitant conditions with this are, say, a lot too. They come along with developmental disabilities, which makes it even harder to find. Epilepsy, hearing loss, and a big one is cerebral palsy. So these patients should be checked for that, certainly more so than other
Right.
types without those conditions.
And another thing I saw, which I thought was a good point, is that sometimes it can be hard to differentiate this from something called amblyopia, because in amblyopia, it often happens in children, and they also are having trouble seeing. But in amblyopia, we can find something that's causing that. Like maybe they have a really high glasses prescription, or maybe they have an eye turn that their brain that pathway isn't developing properly. But in these patients, it's not from the high prescription or the amblyopia, it's from something going on in the brain, not something in the eye.
And the other thing I would say with the amblyopia is usually we can manage those with, doing our, sometimes routine, but other things too during our exam. But some of these CVI patients, we need to bring neuro in there, do a neurological consult, maybe a therapist, occupational therapist. This goes a little bit beyond doing just the normal exam. For a lot of these patients to be able to help them, maybe, utilize the best vision they have, the best binocular, the best stereopsis, to try to help them to see overall the best that they can. And when I say the best, it may not be 20/20, but, if we can get you seeing better, 2 lines better or 3 lines better or one eye better than the other, whatever we can do to get you the best that we can, we want to try to do that. And we all realize that, hey, some patients will never see 20/20. I mean, we all have patients who have nystagmus, and that has a little bit of an eye flutter where the eyes kind of go back and forth. And typically with patients who have nystagmus, 20/40, I think, is pretty good on those patients. And so we realize that, one shoe doesn't fit all. We want to just try to do the best we can for whatever your condition is.
And making sure in these cases, if it's not already diagnosed, that, like you said, you get to a neurologist to see what might be causing the problems in the brain, and if there's other treatments you need for that condition as well.
As far as I know, there's only one doctor who does traumatic brain injury, and he's in Tallahassee, Dr. Maitland, and I'm sure he sees these kind of cases too. But getting the diagnosis confirmed would be important too. But that's the only resource we have that I know of locally.
Yeah, I mean, I guess in some of these cases, maybe the diagnosis is clear cut, right? Based on some, we know they were premature, and we know, they have a certain metabolic condition, or maybe they had a seizure or a head trauma. So in those cases, it may be a little bit more clear cut. But in some cases, it's just trying to go through diagnosis of exclusion, trying to figure out what is leading to the visual impairment, or the cortical impairment, I should say. That's more attuned to what's happening in those cases, and trying to help them out the best that we can. So bring them in. Certainly we'll be first line, and then any of these patients, if there's anything we cannot do, we're going to certainly get them referred to the appropriate doctor, whether it's, you said Tallahassee, is that what you said? Tallahassee, or wherever we need to send the patients for whatever condition they have. We want to get them to the best specialist that we can to help them out.
I think another good resource, if they're already working with neurology and things like that, is possibly even like a low vision specialist. And those are people that specialize in people with reduced vision, and finding them tools and things that can help them, do their daily activities, and, like Dr. Bell was saying, see as best as you possibly can.
The other thing you have to watch for, this can get very complicated in terms of kids who have visual hallucinations as a function of losing most of their vision. That's called Bonnet syndrome, and that has been known to happen in children with this condition. And that requires psychotherapy, and that gets very complicated also.
I think another thing to kind of be aware of is sometimes in eye care you hear the term cortical blindness instead of just like cortical vision impairment, which that is more common, I think, in adults. And I think we most commonly think of that when people have a stroke that affects their visual cortex and that causes them to not be able to see. Whereas what we're talking about is a little more in kids and people with their pathway still developing, which I do think a stroke could be one of the causes, but it's more so when you're younger and the pathway is still processing.
Yeah, I mean, I've seen, I guess in the last 6 months, I'm trying to think, I've seen quite a few patients that were a little bit older that had strokes, and in those cases, I guess it was more about double vision. You know, they had a stroke, and all of a sudden they're starting to see two images, whether they're side by side or on top. And sometimes that'll kind of work itself out, but you know, seeing double, it'll scare you initially, and certainly we want to look at those patients and see what we can do to maybe try to get it back together. And I see that a lot with diabetic patients too, where they're seeing double. But come in, if you're seeing double, you know, you're seeing something that's off, that, hey, what did this happen? I haven't seen this before. You know, give us a call. We want to figure it out. Because it's not normal to see double, and you know, sometimes it's temporary, sometimes it can be more permanent, but certainly there's things we can do to help you to reduce that or eliminate that double vision. Anything else you want to add on CVI that we haven't covered?
I would just add kind of what you were saying, that especially with kids, I think it's important just to bring them in for a regular eye exam, because even if it's not something this serious, it could be amblyopia or something that we can easily help them with that they may not realize they have. I think a common one is if kids have one eye that sees well and one eye that sees poorly, you may, as a parent, you may not notice they're having trouble seeing because they're relying on their good eye. But if you bring them in for an exam, we can help strengthen that poor eye, because as they get older, the ability to improve that vision kind of becomes limited. So I think just in general, bringing your kids in for an eye exam when they're young is good for a lot of different reasons.
Well, Americans in general don't like preventive health care. They're just attuned to, we're going to get a symptom, then we'll fix it. And I think that's kind of a backward view of things the way it should be. And you should think an ounce of prevention is worth a pound of cure. And getting all this done initially is critical in kids.
Well, it's not only better for the patient, it's actually probably more cost effective if you were caught on the front end than on the back end, having to pay to fix it or to go back and to do it. So it's a good point on that. And the good point you said about kids, and that's the reason we try to get them in as early as we can, is because, you know, as the brain is the thing, it tries to help you as much as it can, but sometimes by helping you, it can actually hurt you. In the sense that, hey, maybe one eye sees well, the other one doesn't, and the brain starts utilizing the better eye, and it does that year after year. You know, that other eye may become a lazy eye, it may be shut down, you may suppress that eye, and the longer that happens, sometimes the harder it is to go back and correct that.
That pathway is developing so much when kids are young that if it doesn't develop at that age, it's pretty hard to get it to catch back up later in life.
And that's what I tell. We all, you know, with some of the kids, they don't realize. They'll say, "Oh, I can see," and yes, you can see, but your one eye is really doing all the work. If you don't wear your glasses or a patch, you know, we try to get them to understand at the early age, and it's hard for kids to understand. But hey, this is the time to actually do something. And I unfortunately have adults that come in and are 30 and 40, and they didn't patch or they didn't wear their glasses. And at that point, sometimes it is what it is. We can't go back in time, unfortunately, and get back some of that vision because, again, it's not a refractive issue. It's a brain issue where it has the eye has not been utilized, and the brain has kind of shut it down for years and years, and it's hard to go back and get that back. So it's important. It's important.
I've also had kids ask, well, if one eye sees good, why do I need the other eye? But I usually try to tell them, you know, if something happens to your good eye at some point, you want to make sure you can rely on the other eye. And having both eyes work together helps you get depth perception and all sorts of important cues that you don't get with just the one eye.
But just driving a vehicle. I mean, we all look left and right, and if you only had one eye that could see and the other one, we take for granted we can see, but there's plenty of patients who are amblyopic that realize, hey, you know, you got to turn your whole head around because you can only see out of one eye versus the other one. So it definitely adds a degree of difficulty that, you know, if you can avoid that, we would certainly try to encourage them to avoid that at all costs if they could.
Yeah, it decreases your speed in reading, your speed on a computer screen, and these are all critical issues for kids growing up in their world in the future that will dominate it. It'll be totally visual.
Not to put you on the spot, what's the stat with the learning, with visual? How much is through the eyes and the vision?
Previously, 60 to 65% of all learning was visual. It's now at 80%.
Yeah.
And that was due to the advent of computers, technology, screens, and all these effects, which of course no one ever studied. We just did it.
Right.
And that's the way society works. But
And even with this like cortical visual impairment that we're talking about, that can be one of the things that people can have trouble with is the processing when they're trying to learn to read and things like that.
Yes.
Well, at a critical time with kids learning, we certainly don't want the eyes to be the reason that, they've got enough to worry about without the vision and eyes. So we want to do all we can. Bring them in. We'd love to have you. Give us a call. Go to TerrezzaOptical.com. Going through offices, we have the 4 offices here in Pensacola that we've had for a while. We've got 2 in Alabama. We've got 3 new ones that we've opened. Going through that, but they're all on the website, TerrezzaOptical.com. We take pretty much most every vision insurance, most every medical insurance that's out there. So you don't have to have vision insurance to come see us. If you have medical insurance, like you would use for your primary care physician, and if we can find a medical diagnosis, we can bill your medical insurance. So just give us a call. We have our own billing department. They're very experienced. They know better than we do as far as insurance and how to bill it and co-pays, and we try to be as upfront as we can to patients. I know we all hate going to places and you don't know what it's going to cost, and on the back end they say, hey, here's, you owe us a couple $100, and so we try on the front end and say, hey, you have a copay of this, so patients are not surprised and they know going in kind of what the fees are going to be, or at least what their medical insurance or vision insurance, what it requires.
I think this is a critical point, and that's one of the points of getting as big as we are, is that we're very good at insurance and the things that require a lot of personnel and a lot of overhead to do that perhaps some offices can't afford and can lead to some discrepancies, especially large national firms who certainly with many offices as they have, they cannot increase their overhead to the extent we have, and that's what makes us a better service provider.
I've learned a lot about insurance and billing just working with you guys.
Yep.
So we definitely have people that know what they're doing.
And we're a private practice. We're not tied into any corporate entity. We don't have any specifics as far as, hey, we have to fit this frame, or hey, we have to fit this brand of contact lenses, or we have to do this or do that. We do whatever is best for the patient. We can order anything that we need, whether it be a certain lens that corrects or helps with migraines, whether it be frames that help with hearing, whether it be a multifocal contact lens, RGP, whatever, you name it, we can get it. We don't just say, hey, we fit this one particular brand. If you want something else, you got to go somewhere else. We fit it all. So we'd love to have you. You give us a call, TerrezzaOptical.com. Give us, whether it's for a full exam, an office visit, come see myself, Dr. Bell, Dr. Terrezza, Dr. Martin. We'd love to see you. Thank you guys for listening, and stay tuned for future podcasts. Thank y'all.